Today our topic is Down syndrome in pediatrics. Children with the Down syndrome are the diverse population, and there is a spectrum of features that are associated with disability. Named after the Langdon Down, who first identified the phenotype, it affects 1:1000 live births in the UK. The underlying cause is aneuploidy trisomy 21, and it is this addition of a genetic information, including the critical region 21q22.3, which disrupts the expected environment development, producing the dysmorphic features and mild to the severe cognitive impairment. It is the most common chromosomal abnormality in the UK. The prevalence, however, remains static since 1989 due to the selective terminations of the approximately 90% of the antenatal diagnosis. 95% of the Down syndrome is the result of the trisomy 21, where there are the extra copies of the chromosome 21 in each cell. Instead of having the normal 46 chromosomes, there are 47 as demonstrated. This abnormality occurs sporadically during the cell cycle. In a small amount of cases, the additional chromosomal material is inherited from one of the parents who carries a balanced translocation, including the chromosome 21. Even more infrequently, it may be the secondary to the mosaicism, where there is a mixture of some cells containing the three forms of the chromosome 21, which others are typical with 46 in total. Occasionally, in these individuals, a mild phenotype is expressed. However, this is variable one. This karyotype shows the three copies of the chromosome 21, trisomy 21. There is evidence that the sporadic mutations are associated with the maternal maturity. For example, at 35 years, the risk is 1:270 jumping to 1:50 at greater than 45 years. The majority of the Down syndrome diagnoses will be identified in the antenatal screening, a combination test including the biochemical markers in the maternal period 10-14 plus 1 weights, and the initial translucency on the ultrasound scan 11 plus 2 plus 14 plus 1 week provides a pre-test probability. A quadruple test is offered to the women presenting from the second trimester onward. If there is a risk of greater than 1:150 invasive diagnostic tests, they are offered in the form of chronic well sampling or the amniocentesis. This carry a 1% of risk of miscarriage. The UK government has recently approved the new antenatal diagnostic test with the specificity and the sensitivity superior to the current mode of testing. At near 100%, this measures the self-fetal DNA present in the maternal blood. At this point, this can be done earlier and with the hope of preventing the need of invasive and the risky diagnostic testing later in pregnancy. Down syndrome diagnoses are also identified postnatally, either due to the decline or the missed antenatal screening or the false negatives. These babies may be identified by the dysmorphic features. Down syndrome is associated with the following condition, and there is an increased incidence which dictates the initial management and the subsequent health surveillance. These are detailed according to the system: visual problems, congenital cataract, infantile glaucoma, strabismus and the nystagmus, hearing difficulties, predominantly conductive hearing loss. Ear, nose and throat. The small upper airway space causes the increased risk of infection, particularly the glue ear. Preponderance to the obstructive sleep apnea with the subsequent complications of a daytime somnolence, obesity, hypertension, and the eventual risk of corporal anomaly. Cardiac abnormalities affecting the 40 to 60% of children, typically AVSD, 20% of the Down syndrome, and the 25% of AVSD diagnosis. Respiratory. Recurrent chest infection due to the silent aspiration and the impaired immune function, specifically cellular immunity. Gastrointestinal, the 7% of children with half GI tract abnormalities, including the esophageal ataxia or the trachea esophageal fistula, duodenal ataxia, and the imperforate anus. Slight increase in the Hirschsprung's, but typically worse outcomes of this affected one. Musculoskeletal one, hypertonia, particularly in the neonatal period, often manifesting with the early feeding difficulty, increased risk of the atlantoaxial dislocation, which needs to be considered in the children presenting actually with the neck pain. Growth and development. Poor growth and the short stature are common. This or separate Down syndrome growth charts available. Development. So the development delay is universal but variable, although some children may eventually live independently and gain the employment. Skills are likely to be acquired at the slower rate. In particular, the gross motor and the speech development will be acquired. Despite the level of the neurodisability and the developmental impairment, children with the Down syndrome are often socially very able. Endocrine one, the increased risk of hypothyroidism. Hematological one, unique to this syndrome is transient myeloproliferative disorder (TMD) affecting the 5 to 30% of the neonates. As the name suggests, this is transient, usually correcting within the 3 months. There is a subsequent increase in the risk of acute myocardial ischemia. Differential diagnosis. The antenatal testing identifies the risk of trisomies 13, 18 and 21 paired to Edward and Down syndrome. Phenotypically, these are distinctive from each other. Once a trisomy has been identified, further test D-brain-did analysis confirms the trisomy 21. It is important to carefully examine for the features of the Down syndrome if the related diagnosis is identified in order to differentiate whether these are distinctive or the part of syndrome. Whether there is antenatal diagnosis or high clinical suspicion, genetics need to be confirmed in the early postnatal period. The DSMIG outlined appropriate course of action for the initial management of the neonate with the Down syndrome. Much of the management is routine for all newborns, such as full newborn examination, ensure the meconium and the urine has been passed, and the review of feeding. However, care needs to be conducted with the higher index of a suspicion based on the anticipated problems. Early management includes the senior pediatrician and the midwife to attend to the family a new education initiative by the Down Syndrome Association, Delayed Right, Started Right, urges those managing these families to have the correct and the most up-to-date information and the early counseling phase. The blood test like QF-PCR test followed by the G-brain-did analysis to identify the trisomy 21 full blood count and the blood film DSA neonatal. The newborn eye assessment, universal newborn hearing screen, uterine test, newborn blood shot on day 5 to screen for the congenital hypothyroidism, electrocardiography and the echocardiography. Management. The Down syndrome children are managed by the multiple disciplinary team whose care is normally coordinated by a community or the neurodisability pediatrician. Families will receive the personal child health record as an additional insight for the Red Book, which has condition-specific information with which to guide the care. Other specialty input is dictated by the associated comorbidities, for example by the cardiology, ENT or the respiratory physicians and surgeons. The overall aim is to treat any associated condition, promote the health and the development, and reduce any disability or the function limitation. A routine schedule is advised by the Down syndrome medical interest group. This is a system approach to identify the possible growth delay, respiratory or the cardiac problem, and the investigation of the thera function and the audiology assessment. Where the families are planning subsequent pregnancy, genetic counseling is offered and the karyotype analysis will be performed to indicate the risk to future offspring. And the complications will be like life expectancy is highly reduced to 60 years and there continues to be increased morbidity in the later life, in the particular increased incidence of the Alzheimer's dementia. Thank you.